Hello, everyone, and welcome to today's keynote presentation, Costly Closures, the Return on Investment in COVID-19 Prevention for Retail, Schools, Sports, and Entertainment. This webinar is part of the coronavirus virtual event series, and I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots. So let's get started. Before we begin, I want to remind everyone that this event is interactive and we encourage to participate by submitting as many questions as you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. And if you have any trouble seeing or hearing this presentation, simply click on that Ask a Question box located on the far left of your screen. As a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credit tab located on the top right-hand corner of your presentation window and follow the process to obtain those credits. I now present today's speaker, Dr. Blythe Adamson, the founder and epidemiologist at the Infectious Economics. For a complete biography of our speaker, please visit the Biography tab at the top of your screen. Dr. Adamson, welcome. You may now begin your presentation.
Wonderful. Thank you for having me. So my talk is going to be quite different than a lot of the other keynotes that you've had in this series. And I hope that it spices things up a little bit. I've got quite a few more photos to show than I do graphs today. So again, my name is Blythe. It's nice to meet you. I'm an applied epidemiologist, and my specialty is in the prevention of infectious diseases. So I do this with a lot of tools. It requires me to code in 12 languages, to analyze complex electronic medical records, and build a lot of math models of the dynamic transmission of diseases. But I'm also an economist. So with that, it means that into these models and calculations, I'm also considering what the cost is of prevention and what are the resources required to get the outcomes that we want. Because we'll often have to make trade-offs, and that's really important for the design of good public policy. And as we'll talk about today, policies for private businesses and ways that we can really both on one side, help reopen our economy while also really valuing and preserving health in our population. So, often when I'm in a room, there's a conference room table, and on one side of the table is all the health people. And they all, often really want to maximize health at any cost. And on the other side of the table are the economists. And they want to maximize GDP, minimize unemployment, and get economic recovery and productivity back again. So I end up often in the middle of those two, being the translator between those two disciplines, who often use different words to describe the same concepts in math. So this is what my screen looks like on many days pre-pandemic. But because of this very random intersection of disciplines where I fall, in early March of 2020, I was called into FEMA as an emergency responder epidemiologist, and then quickly called to be the lead data scientist in the West Wing of the White House. So stayed there working with all of the health officials and economists through the worst of the spring waves of the pandemic. Was incredibly difficult, but the stories about the White House are not what I'll be sharing with you today. Really, what I want to talk about today are things that have happened on the other side, on the downswing of this pandemic, as we figure out what is life going to look like. How soon can we get things open again? And I, as someone who really loves challenges and trying to think of ways to do really hard things, I really saw an opportunity to help guide safe ways to do large in-person gatherings again. Now, in a pandemic, this seems like a terrible idea, but we got to figure out how to do it somehow. And so the focus of what I'll be talking about today really is on decisions that private businesses are making in order to gather together large numbers of people from different households together in person, and really for something that happens over and over in time, so recurring events. Now, categories of this, from this sector that we think of in the economy can include sports, leisure events, theater, concerts, and the ripple effects of who this touches, the jobs that this touches, really includes the travel industry and hospitality industry as well. And so with all of the 5 million jobs that we are still missing from pre-pandemic, what is it going to look like for us to be able to safely get things open again? So I want to start by talking about the NBA, because of all of the major sports leagues, the NBA has clearly been the leader in beginning again and investing the resources and taking coronavirus very, very seriously. So what we saw in mid-2020 was the NBA bubble. And I'm so incredibly impressed by everything that the NBA has done to make data available to researchers and for all of our scientific community to learn from the rich data that was generated in the NBA bubble and in the NBA season last year. So the first thing I want to describe is why they were able to do this so well. So it was a time early in spring of March 2020 when we really didn't know for sure what the probability was of someone experiencing symptoms or being asymptomatic with COVID. And because of that, we really didn't know how many people were truly becoming infected with COVID, because so many of the true infections were invisible to us, especially with that original lineage. There were many fewer people who had access to testing if they didn't have symptoms. And so a gift of the NBA was the Sequential Testing program that they implemented. Now, they tested players and staff every single day with PCR testing. And this really is one of the richest data sets that we have in the world to understand what the beginning of the curve of viral dynamics looks like. Because unless you're testing someone every single day when they're negative, you really don't know how long the uphill is of the viral load curve. And so they tested these players every single day, actually 2 different ways. They did a nasal swab, and they collected saliva tubes. Now, it's the NBA's investment in Yale University that helped develop the now known as SalivaDirect test. And this was an incredible gift because it has both increased access to high quality PCR testing in the United States while also lowering costs. I like to make the analogy of, instead of getting a fresh direct box with like a kit to do PCR, just like you're making enchiladas for your family. When you need to make enchiladas for the whole block party, you just need to go to the grocery store and buy the cheapest of all the ingredients that you can get access to and make as many enchiladas as you can. That's how I think about PCR tests. There was a shortage of many of the different reagents that we needed, and SalivaDirect through Yale and the NBA was one of the great solutions for that. And doing these double swabs every day is what helped allow validation and development of that. So one of the early learnings that we had really was that the peak viral load for people who were symptomatic versus asymptomatic was very, very similar. And that meant there was a question at the beginning: are people who don't feel any symptoms as infectious as people who do feel symptoms? And what we learned is the answer is probably yes. They probably are very similar. But the key difference is between symptomatic and asymptomatic, and I think that there's a real parallel here for what we're now seeing among vaccinated compared to unvaccinated individuals, is that the duration of infectiousness was shorter for people who were asymptomatic compared to symptomatic. And now that we have similar data from daily PCR testing now in the summer and fall of 2021, we see something very similar. Vaccinated people, we're observing, have similar peak viral load, maybe a little bit lower, but their duration of infectiousness is much shorter. So the NBA has been incredibly successful, but at that time in the bubble, they didn't have audiences, access was very restricted, and players didn't even have access to their families, or the staff didn't have access to their families. Things were kept in very tight lockdown. So what did things look like when we tried to open up and all of the different sporting leagues tried to develop their own protocols? Well, so I, as a member of the COVID Sports and Society Working Group, I have the privilege of meeting every week with sports leagues to understand what policies and decisions they're making for their teams, what are the outcomes they're seeing, and how often are we seeing outbreaks associated with different sets of policies. So we can go back to the July of this year to a game that was about to become very famous, which was the Yankees against the Red Sox. I think this was July 15th, but shockingly announced to everyone, the game is canceled. All the tickets that had been sold, no one's allowed to come, and people were just devastated. And this was one of many games, not just in baseball, but across many different sporting leagues, that even with wearing masks, doing testing, we still continue to see outbreaks. Now, I will say that it has allowed us to learn a lot of things. One of them is that we still don't see evidence that other than hockey, that transmissions are happening on the field or on court. One of the riskiest places we are seeing for transmission of SARS-CoV-2, which won't surprise you at all, is in the locker room, and sometimes in transportation if there's not good filtration or open windows. So what does this look like for other groups? Theater has tried to reopen. We have maybe half of Broadway in New York City reopened again. Yet, even still, with different testing strategies, this was the same week that this is 4 days after the Yankees versus the Red Sox were canceled because of an outbreak. We see in London that Andrew Lloyd Webber New Cinderella was also canceled. But in this case, just because of one positive case. Now, it is interesting to see how different countries' policies affect and pressure and put risk on different businesses. At this point in time, the UK had a different quarantine policy after exposure to COVID than the United States. And so it would have actually been much more difficult for production to stay open in London than in US at that point in time. And I think the economics of this are really interesting because, each business has to think through, how much am I willing to spend on prevention? It just seems like testing could be really expensive and, that's out of my budget. And, I really like to think through what's the probability that you're going to have to cancel this concert because of an outbreak, or this game, or this show. Now, it's much easier, I think, when we think about the sphere of entertainment. TV and film really do fall within a different category for two reasons. One, when there's an outbreak of COVID on a TV or film set, it often costs millions of dollars a day because of the equipment rentals and extending the schedules. But it can often happen without anyone in the outside world knowing about it. And the number of people it impacts is much smaller than the way that we think about live entertainment events, where thousands and sometimes tens of thousands of people are affected if an event is canceled that was intended to be live. So, on Broadway, an average Broadway show within 1 week has a gross revenue of, over $1 million. And so if there were an outbreak in a cast and production, the cost to cancel that means, immediately losing $1 million of ticket sales. So then all of a sudden, if you multiply the probability of canceling by the amount of money that you will lose if you have to cancel, it becomes much easier to define the threshold of how much you might be willing to pay to reduce the likelihood of having an outbreak and a cancellation. So then it becomes easier to budget for COVID safety managers, signage, appropriate PPE, and training. I didn't include training on my list, but that's an important one too. And then testing, I think. I see many groups who, for cast and crew or concert performers or players of these different live events, have ranged in frequency of testing from once a week to multiple times a day. Now, I do see for individuals to do their job on a stage or a court or a field who must take off their mask, often weekly testing is not sufficient to identify cases. And so I do see frequency ranging between, 3 to 6 days per week of PCR testing many of these core individuals in order to pick up a positive early enough that you can pull them out and prevent an infection. So, those costs can run high. Even on TV and film sets, we're seeing budgets, per TV and film production, around $400,000 a week just on PCR testing alone. So this is, a very delicate balance of costs and benefits that these productions and leagues have to make regularly. So what really are the attributes that we're thinking about with super spreading events? It's been something that's been hard to predict. The heterogeneity of infectiousness among people has been something different about COVID-19 compared to other viruses that we've seen. We see generalizations and describing it as, most people with COVID don't spread it to very many people, but some people with COVID spread it to a lot of people. And I think we've done a good job describing environmental attributes that are associated with super spreading events, like being indoors, choosing not to wear a mask. But there are also many attributes of the individual hosts themselves that relate to, how potent their breath is with aerosolized virus. And I think that we're still understanding that. There's also the cross-sectional or, instantaneous infectiousness that an individual can have, which may be changing throughout the day. And so it matters when your last test was timed and how quickly you're getting your PCR results back. But then also behavioral factors like, what's the proximity to other people in what type of environments, how many unique individuals are you mixing with? Is it a different number of unique individuals every day, or are you mixing with the same people unmasked every single day? These are a lot of the attributes that we have to factor into our equations. So I want to go over with you the 4 pillars that I believe are really essential for these private businesses, who many of whom I work with regularly, who are the ones actively designing and implementing protocols to keep their casts, players, staff, crew, musicians safe as they do these large events. So my focus isn't, I'll tell you a little more about what we do for those essential employees of these live large group gatherings. And from an audience's perspective, I think that it's much easier to handle since they can continue to wear masks, or we can mandate proof of vaccination. But really, the risks for people to do their job, they have to be indoors, unmasked. There's a whole other level of risk. So the first thing of the four things that I want to tell you is just vaccination. Now, different groups have chosen different strategies, and many of this has actually been led not by the businesses themselves, but by the labor unions. So I often am brought in as the scientific expert in collective bargaining between different unions. And I think that this has been, very contentious, but I've been so grateful that our government has led by demonstrating that their own willingness to require vaccination for many types of government employees and health workers. So the first thing is just everyone needs to be vaccinated. But I think that a lot of the education that I do with these groups is about what vaccination gains us and what it does not gain us. So many people in the general public still believe that vaccination completely protects you from becoming infected and being able to spread it to other people. And so I hear a lot of, even VIPs in these different organizations say like, well, no, I don't need to wear a mask because I'm vaccinated. Yet, I myself and many of my on the ground investigations, I'm still seeing super spreading events among fully vaccinated groups. And so a lot of the work that we have to do is helping the general public understand that these vaccines are incredibly effective at preventing hospitalization and death and protecting our body by training it to be ready to fight off symptoms. But the likelihood that it's going to reduce our risk of becoming infected, I mean, that benefit may only last 2 or 3 months after vaccination. And then, as I'll show you with some NBA data on natural reinfection at the end, it's beginning to look like a similar amount of people are becoming reinfected and susceptible and transmissible in the months after vaccination. The second pillar that I really believe is going to have tremendous benefit, not just for live events, like for leisure and sports and entertainment, but also really for corporate office spaces, is air filtration and air quality and ventilation. So number 2 really is ventilation. So the components that I see for these events as being incredibly important, the 3 different parts of it are ventilation, so HVAC systems, bringing in and mixing fresh outside air and upgrading these HVAC systems to incorporate MERV 13 filters or higher. Now, you can have 6 to 8 air changes per hour in your large space, and that can be great. But you could have 100 air changes an hour, and it still probably wouldn't protect you from becoming infected from the person just standing right next to you without a mask on. And so we need more than just an HVAC system with great filters inside of it. So the second part of clean air that I really recommend and often add to modify these spaces that people are working in are portable air filters. Now, HEPA is great, more than necessary, I think, to filter out coronavirus from the air. You really just need MERV 13 or higher. But these are key, especially for places like locker rooms or small offices that have low ceilings or dressing rooms. These are all places that we've identified as being high risk for transmission. And it's through recycling and purifying the air in those rooms that we can supplement and enhance the efficiency of the HVAC system in the building. And then the third tool that we have really within this clear air category is just using fans. I'm just talking $30 box fans have been an incredible tool. And I like to use them in two ways. One of them is to create turbulence in the room and, mix up the air in the room. So I often like to say, if you can smell my fart, and you can catch my COVID, just to help these groups get the concept of an aerosolized cloud and the types of risk that you might have. They still often think that it's just proximity to other people, but I've seen many transmissions. For example, one risky area I've seen are recording booths. So, for example, vocal recording booths are tiny booths that have no ventilation at all on purpose because, they don't want any sound to come in and change the recording. And, someone could come into a recording studio and take their mask off and sing their heart out for an hour and then leave. And a couple hours later, another person can walk into that same vocal recording booth and still, walk into this cloud of aerosolized virus hanging in the air. And so fans position strategically outside of spaces pointing in, create the turbulence then to dilute and spread apart that cloud so that as someone walks into a space or through a space, the air that they're breathing in would have a lower concentration of aerosolized virus per breath and lower the likelihood of that individual becoming infected. So I often use them to create that turbulence. And then the other way that we use fans is really strategically, for example, directionally controlling the air. So in long hallways where I notice there are low ceilings, it's a high traffic area, and there's thick, stagnant air because there are no windows anywhere near this. This could be underground at a stadium. This could be, in backstage in an old Broadway theater. We can use fans strategically to identify which end of that long hallway has the cleanest air. Now let's put a big box fan on that side so we're directionally blowing the air across and down that hallway. Thinking about the movement of air also has been incredibly challenging and important for the safety of musicians. So I get a lot of questions and work closely with musicians. It's very easy to help guitar players and piano players because they can continue to wear a mask while they do their jobs. But for players of wind instruments and brass instruments, it takes a lot more care and attention to both do routine, frequent PCR testing to make sure that those individuals are confident about their negative status before performance begins or concert begins, as well as really inspecting the ventilation system and movement of air around those musicians, both to protect them from audience members and to protect the audience from a musician in the very small chance, we hope, that one would be infectious and unaware. So this is just a diagram to show how there's been a lot of research done about these, about how the aerosol virus or how aerosolization with COVID works and how it's even changed with different variants. We do know that the Alpha and Delta strains are aerosolizing in smaller particle sizes and traveling longer distances than the original lineage A that we saw in the beginning of 2020. And, there are a lot of endorsed resources where, as an economist, making recommendations for different, HEPA or MERV-13 grade air filters, you do have to weigh the costs and the benefits. So it's often, you can get great air filters from between $200 to $500. They vary depending on the size of the room that they're intended to filter for, and have other attributes that people are looking for, such as the sound. So you can pay less to get one that's noisier, But if you're going to be filming or playing instruments, then there are often in the groups that I work with a lot of sensitivities to sound and a willingness to pay more for quieter units. So that second point was, the first is vaccination, then ventilation. And third is testing. Now, I've talked about testing a lot before because we learned so much from the NBA and what's possible with testing. And, from my seat as an economist, where I'm off pre-pandemic, was doing a lot of models to inform, what's the value-based price for a new vaccine, or the price for a new drug, or how should we price this new diagnostic test. In order to do that, we have to break down what the dimensions are of value that product brings. And so as we think about workplaces and private businesses implementing their own testing programs for their employees, then we have to be able to understand what are the decisions that they're trying to inform with that type of workplace surveillance, and how can they reduce uncertainty in those decisions or gain the confidence that their workplace is safe, while also trying to minimize costs and the budget impact of that. So really, the accuracy is incredibly important. Now, for many of these groups, the accuracy may not matter very much if you have a lot of substitutes available for that position. So if this is something like an usher for one of these events, you may have a willingness to accept something that is less accurate, like a rapid antigen test, there's a lot of less accurate tests available because maybe there are plenty of other ushers that you could bring in. But you may not be willing to accept a rapid test in one of your most important players or cast members right before a performance, because they're incredibly valuable for the success of that event. And so that's where you might be willing to pay much more for an incredibly accurate result, specifically, an RNA result, so a molecular result instead of an antigen. And I think that the target also matters a lot, because we have seen success across all of the different types of businesses I'm talking about now in the detection of people being infected before they become infectious. Now, I do think that this is one of the distinguishing features of workplaces where people have to be indoors, unmasked around each other in small rooms where there could be a high transmission risk. And this type of frequent testing or daily PCR testing, we've demonstrated over and over again, really can identify someone as being positive when they have a CT that's well above 30, and we can isolate that individual before they become contagious to other people. And I think that that's been one of the keys to the success of containing positive cases and preventing an outbreak from occurring. With specimen type, I think that we've seen a lot more acceptability and demand for saliva-based tests. And I've seen a lot of variability in technician swab technique, of self-collection swab concerns when the individual really does not want to be positive and may not be providing a thorough swab for their own interests, when it really is of the community's interest to be certain about it. And also the invasiveness of just people getting tired of swabbing every single day and preferring to spit. So a lot more demand for that. But we also want to pick and recommend testing technologies that have an adequate supply. And I think that many in the US have felt the pain of the supply shortages recently with many of the rapid tests that are available. And we have to keep the costs down. I think this is where we're seeing pooling becoming not just accepted, but again, an increase in demand from these groups to do pooling, I think that is often what I'm seeing now to be able to get the frequency and make the testing programs like this sustainable while they're still needed. And also from testing, this is a photo of just a board game that I made for one of the Broadway casts that I'm working with. They really struggled to understand what happens if I'm positive, when do I get to come back to work? And it allowed the entire production to be able to simulate through a game how many people would need to test positive before we would need to cancel a show, because we wouldn't have enough human bodies and subs and swings to be able to bring in. So, this brings us to, this is just a picture I think that captures both the what testing can look like in a workplace for one of these live events, and it also shows the number 4 pillar that I think is incredibly important, and that is high quality, genuine KN95 like masks. So masks are incredibly important. We all know masks are important, but I really do believe that to bring large numbers of people indoors together in risky settings, that many employers are making a conscious choice to use KN95 masks instead of surgical and cloth masks. And, I'm seeing this really as a risk mitigation strategy that's used more for being chosen by groups like that if you cancel, it will cost a lot of money. I'm not seeing many private businesses like or retail locations or corporate offices choose KN95s. I think that they're still keeping options open for whatever people feel most comfortable in. But I do see the incredible success of filtering out the virus. And the main challenge has been in the education of how to get good fit. And that is really an important part of the effectiveness of these things. So of all those, I just told you about the components that I think are really important, which are vaccination, ventilation, testing, and masking. And the implications for offices and retail stores are, quite relevant. I think in other types of more common workplaces where you may have 1,000 people gathering together every single day in a corporate office, I often don't recommend the daily PCR testing because it just seems very excessive. But I do think that I do see many corporate offices now in setting up testing programs just so that their employees have access to on-site specimen collection for affordable PCR testing. And this has been really essential when positive cases in the workplace do happen, so that the next time people come in, they can just, give a saliva sample as they walk in, and the workplace can continue to monitor and make sure that that everyone is negative. So just enabling the testing to allow that continued productivity as an alternative to going into quarantine and waiting it out. So let's talk about some of the hot topics that are still being debated. And I put a long list down here just to give you an idea of the things that are not agreed on yet by different groups, that don't have clear answers. And I'll discuss just a couple here that are highlighted in bold, but we can use the Q&A time if any of these other ones are of interest to you. Please throw it in the chat and we can discuss. But a lot of what I hear is, when can we use quantitative PCR results? CT scores are so incredibly helpful to understand if someone was infectious at the time that you swabbed them, but they're really supposed to just be for research purposes only. And the FDA has not authorized any of these tests for SARS-CoV-2 to be able to return that CT value to the patient, because not enough is known to have confidence that that should be guiding any of the treatment decision-making for an individual patient. But what I am seeing a lot of are epidemiologists in the field using these CT scores to guide the response during an outbreak and to help guide confidence in containment. So, if you were to in one day identify 10 people who are positive, and you can see that 9 out of 10 have a CT of, 31 and higher, and one person has a CT of 14, then it becomes much easier to start putting the pieces together of what might have happened in that super spreading event. And I continue to get a lot of questions about, how long should we keep people out of work once they do become positive? So that's where, CDC tells us 10 days of self-isolation. But it's actually the labor unions that I'm seeing are adding on more restrictions even than CDC's guidance. So many groups require a clinic visit with their healthcare provider to get clearance before they're allowed to come back to work. I personally don't think that that's a very good strategy at this point in the pandemic. We already have constrained healthcare resources right now because of the burden of COVID, that I think that it can be unnecessary to take a healthy person after they are no longer contagious and use the healthcare system for an approval. It could even put someone more at risk going to a clinic after recovery from COVID just to become infected with something else. And I think it's also very tragic when I've seen many groups where their employees do not have health insurance. So after being unemployed for 18 months during the pandemic, return to work, become positive, they're out of work then for 10 days, unpaid for 10 days, don't have health insurance, and the gating to come back to work is a healthcare clinic visit just to get clearance. So, I think there are still a lot of policies and clear scientific recommendations that need to be made so that employers and unions and non-scientists can understand what the crystal cut criteria should be for an individual to return back to work safely. That doesn't put unneeded, financial or, health risks onto these employees to get back to work. So I'm just going to wrap up now with us looking back again towards the NBA. Like I said before, just one of the most incredible leaders, both just in the development of policy and the value of health of their players, to show some of the data from the most recent paper that has come out on reinfections. And, this is among, mainly young, healthy men, and we're seeing the infections go to ranging from, like, most of them are all more than 100 days after their first initial infection. So let's see, I think I actually have the average. So the average time was 152 days. Was when they became reinfected after their first infection. Now, if you look down on here, there is one case number 7 at the bottom, who's very different than the others. And I would like to highlight from the beginning that this individual became reinfected very, very shortly after their first infection. And, it was confirmed through sequencing that these were 2 different viruses, but it was learned that this individual had an immune compromising condition, and that is likely why they experienced a very different set of symptoms during their first infection, then did not have antibodies following it and became reinfected again with a meaningfully high viral load. But aside from case number 7, the average peak viral load for these individuals when they were reinfected was about 28, a CT value of 28. And compared to the same group of people in their first infections, had a mean peak viral load of 22, of CT of 22. So that, roughly translates to the reinfections had a slightly lower viral load the second time they became infected, but it was still within, for most of them, still within a range that we would consider to be infectious to other people. It is noticeable too that the days from reinfection onset to being cleared with 2 negative test results consecutively was a shorter time. So clearance happened sooner. And I think that this is really interesting because it really parallels exactly what I'm seeing in outbreak investigations of people who are vaccinated compared to unvaccinated. So there are a lot of parallels that we can learn between those. So, in conclusion, I just wanted to say that, it's really hard work, I think, taking all of what we know about the science and the meat of the scientific presentations that are in the rest of this coronavirus virtual event series and translating it into public policy for the real world. There are still going to be bars and restaurants open and full of people. There will still be people that are choosing to remain unvaccinated. And, I think to me, one of the most important metrics that I like to follow is how many cities there are in our country that do not have any capacity in the ICU. Because at that point, it becomes a weakness and vulnerability of our healthcare system. That if someone were to have a heart attack or get in a car accident and not be able to access the healthcare they need, to me is not acceptable. And so I think that we will continue to work in developing smart, responsible public health policies, both at a national level, at a local level. But really, I just want to encourage you and recognize all of the private businesses that are really trying to do the difficult work of taking general public health guidance and making it practical for the situations that they're living in. So with that, I'd like to just thank everyone for joining and sticking with me. And I'd love to hear any of your questions. Thank you.
And thank you, Dr. Adamson, for that informative presentation. We will now start the live Q&A portion of our webinar. And if you have any questions you want to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen. So let's get started. It looks like we already have some great questions coming in from our audience. Our first question, what workplace conditions should require wearing a KN95 mask?
Great question. So I like to think of those 4 pillars as a table, and you can take away one of the legs, but if you take away 2 of the legs, it all falls down. So in my mind, a high quality mask like a KN95 is definitely needed if you are uncertain about the vaccination status of the people around you. There is no ventilation in the space that you're in. It's an indoor space, or you have to work in an environment that doesn't have filters. There's no exterior doors or windows that can open, and you don't know what the infection status is of the people around you. So there's no routine testing program. You're just to do your job, trapped in a really small space without fresh air, and you don't know if people are vaccinated, and you don't know their testing results. That's a situation that I would say you should definitely wear, or employers should definitely mandate KN95 masks to mitigate risk. Now, I would say many employers will choose KN95 masks in high stakes situations where they really don't want individuals to become infected so much because they can't work from home to do their jobs. Or the entire, event or something would have to be canceled. So some will just do it as an extra mitigating step, but absolutely in the first set of conditions I described, KN95 masks would be necessary.
Thank you so much. Our next question from our audience, what is the ideal frequency of PCR testing for workplace surveillance?
This is a great one. I think that it really is dependent on two different factors. One, what's the burden of COVID in the community? So what's the likelihood that people in that workplace are going to get infected so I like to divide it up in, you can get infected in your household through the people you live with, you can get infected in your community from, going to a dinner party, or you can get infected in your workplace where you spend a lot of your time. And workplace policies can do a ton to mitigate the risk of a transmission happening at work, but there's not much a workplace can do to prevent you becoming infected in your home or in your community. And so the likelihood that you show up at work positive, that really is one of the main factors determining how frequently someone should be testing. The other element of what goes into the decision of frequency is when was the last positive case in that workplace. And so if this workplace hasn't had any positives in several weeks or in a month, I think that I am seeing many that are slowing down the frequency of testing. So maybe they test once a week just to see any, and they're still not getting any. So maybe they just test, once every 2 weeks. But once that, if you start testing every 2 weeks and you start seeing cases pop up again, that tells you that now you're not testing enough to pick up these infections, or you're not testing enough to understand, is that spread that's happening in my workplace, or are these just infections happening around the same point in time, but they're just both, they're unrelated to each other. So many workplaces, in just setting up a testing program, might make it available to their employees once a week, but then really have it there as a way to respond once positive cases start happening.
Thank you so much. And again, I want to thank our audience for these great questions coming in. Our next question from an audience member, this person says, comment and question on spreading of COVID. For individuals who are the majority of the vulnerable population, the effort to just get a test as soon as possible is daunting. CVS hardly has anything sooner than 3 days, then add 2 days to get results back. The sooner you need the test, the tougher it is. The easy test centers take a week to get those results back. This is really working in favor of the virus. What is being done to cut this time that it takes to get a test and the results to a day or two?
This is such a great question.
Yes.
I think that our federal government is doing the efforts that it can to increase the supply and lower the cost. Yet we're still feeling the pain. And it's very different depending on where you are in the country. And as an economist, I like to think, it is kind of inefficient for all of us to be working as individuals in trying to get access and pay for these tests. And so I'm seeing a lot of success when businesses and when the employer is directly contracting with a lab to create access to a big supply of tests at a bulk discounted rate. And so this ends up being a win-win, because the employer both, they're making sure that their employees have access to tests. They're getting the cheapest price possible. They're ensuring that they have the supply because they're pre-contracting a minimum quantity of tests that will be used. And then contractually, they're able to say that test results have to come back within a certain amount of time. Otherwise, they're not going to pay for them. And they will also, many of them include contractually the option to pay a premium to get the results back even sooner. So I do think that it's hard for the federal government to, it's a tough job to create an abundant supply of tests for people to seek individually. And so I am seeing a lot of success with employers being the ones to create that access and faster turnaround time.
Thank you so much. Now, how should private businesses define a threshold for when to close a workplace?
Ooh, this is a spicy one. I first, with many of the groups that I worked with at the beginning, the threshold was just defined for them by when you run out of humans to do that job, you have to close. But then, depending on the organization, groups started just figuring out or having quite a depth of people who could replace those roles. And so we don't want to end up in a place where we are creating a workplace environment where spreading is actively happening all the time, and it's just a continuous outbreak, but we're just putting more and more bodies in to replace the ones that are in isolation. We don't want that. So I think that a threshold really is related to containment, so that it's okay to backfill positive cases, but if you're starting to see tertiary and quaternary infections from a spreading event that happened in the workplace, then to me that flags an area for serious concern and further investigation. So this is where many of the groups that I work with, and I'm seeing this used by a lot more epidemiologists, are what we call precision epidemiology investigations. And that's where we use genomic sequencing to sequence all of the positive cases within a workplace that are clustered around the same period of time, or maybe the same area of a workplace or a production, or a team. And through sequencing, we then just compare the viruses to understand how similar they are to each other and estimate the likelihood that we think that the transmission had happened in the production or the team within the workplace, or be able to tell, oh, these viruses are totally different from each other. We're pretty sure that these two people just separately became infected in their own communities and then came into work positive around the same point in time. And if it's the latter, then great news. Safety policies are working. People will become positive, from home and community. But then if you find out that, oh, these are almost identical viruses among this whole group of people, then that's the time where it becomes the employer's responsibility to closely review the safety protocols and make revisions to patch them up and ensure that a spreading event like that won't happen again, or reduce the risk.
Thank you so much, Dr. Adamson. We have time for 2 more questions. Our next question: what do people need to do to get back to work after natural infection? And the second part of this is, when is a 10-day isolation, negative test, and healthcare provider clearance necessary?
Ooh, so I mentioned that I really don't think that the clearance is necessary for people who were asymptomatic or who had mild symptoms that improved over time. But I definitely don't think we should be gating on having to have a negative test before we go back to work. I've seen people who are testing positive for months and months, sometimes more than 100 days, and we can't make them be out of work for 100 days. But I am seeing many union protocols just out of not conceptually understanding the difference between a positive PCR test result and a level of virus active infectious virus that could be a risk to others. Yet in the same way, I do see many opportunities to bring essential employees back sometimes sooner than 10 days. Now, I think that this really is then gated on multiple negative PCR tests, 24 hours apart at least, consecutively, so that if an individual does become positive, for example, someone who's fully vaccinated, they might test positive for 1 or 2 days and then go negative. They don't experience any symptoms at all. And the multiple negative test results tell us that they're not infectious to others. I don't consider that to be a false positive case. I really think it is becoming more of a profile of what I see among vaccinated breakthrough infections, And the 10-day isolation then is not always absolutely necessary.
Thank you so much. We have time for one more question. Let's talk about children. Should unvaccinated kids test to stay in school instead of quarantine after exposure? And can parents of infected children return to work?
I love this dilemma because I think that with kids, the same concepts apply in school. We want great ventilation. We want doors to be open, windows to the outside to be open. We want to bring air filters into the classroom. We want routine surveillance testing to pick up kids as soon as they're positive. And we want masking. I think that masks it's been amazing how tolerant children have been to wearing masks when they go to school. But, we know the kids are still less likely to become infected, less likely to pass it on to other people and experience symptoms. And I really do think that test to stay is going to create more benefit for children than, assuming that all children should quarantine after an exposure in the classroom. I think that we have to weigh the risks and the benefits here for kids. And I think that, the social, emotional, academic development of kids is incredibly important. And we've seen this modeled out in the UK, not modeled out, but actually tested out in a randomized experiment to show that they randomized schools so that some of them quarantined all children when there was a positive, and some of them tested all of them after an exposure. And they found out that with testing to stay, children spend a meaningful amount of additional days in the classroom, and they did not see a higher rate of new cases because of it. And so if we can get the access to affordable testing for school districts, I think this can be an incredible tool to keep kids in the classroom.
Absolutely. Thank you, Dr. Adamson, for this great presentation today and for important research. Do you want to provide any closing remarks before we go?
No, just thank you to LabRoots for inviting me to be part of this coronavirus event.
And thank you again for your presentation today. And before we go, I want to thank our audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period will be addressed via the speaker using your contact information you provided at the time of registration. And this webcast can be viewed on demand for 2 years until October 2023. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care of everyone. Stay safe. Bye-bye.